And
That'll do
now
it.
you are host, Aidan. There you go.
Fantastic. I was going to say that it won't let me share, but now it will. Okay, I think what we're looking for is this one.
And Aidan, I apologize, but we were just in team meeting and the person hosting accidentally shut their computer. So there will be more people coming on because 10 people just got booted out by accident.
Oh
So
no,
my apologies. They will be back.
that is fine. I think this is showing everything, not just the thing it's supposed to show. This isn't just
And
showing.
Aidan, before you start the presentation, I hope that you'll talk a bit about yourself because I'm not sure everyone knows what an interesting breadth and depth of background that you have.
That,
So
that's the plan
feel
we're
free
in
to
here.
humble brag. Don't be Canadian. In that way.
Uh,
Do you want me? Are we recording already? It is being recorded. Okay.
We are
Do you
recording.
want me to do an introduction or do you just want to fly with it, Aiden?
I'm happy to fly with it. I'm used to
Okay,
this kind of thing.
awesome.
Right. So I'm
Yeah, I've
sharing.
kind of pre-stacked some questions to ask afterwards if we've got the time, but I'm really looking forward to being able to sit back and participate.
Excellent. Yeah. So we'll give everyone a few moments
Yeah.
to jump in. I'm seeing there's what, six of us in here.
Eden, I think because you're host, you'll have to let people in. I
Yes, I'm getting
apologize, there
little.
wasn't co-hosting. So if anyone shows up, you might need to pop them in.
That's fine. I've popped. There's a few that's popped up, so we're getting
Okay.
them in as they go, which is great. So we'll we'll jump in. I think that's probably wise to jump in. And this doesn't cover. No, good. Can put it there. Good. Sometimes Zoom is funny. Sometimes Zoom is not. Today it's decided to not be funny, which is excellent. So, hi everyone. First of all, I'm just so pleased to be here, and I guess I want to uh, reiterate just how excited I am to be able to nerd out about psychology to a captive audience effectively. So thank you so much for the opportunity. Thank you so much for the invitation from Ottawa River Integrative. Karen, I think in particular, you approached me. So thank you for that. And thank you for being here. Thank you for giving up some of your Friday to come and listen to me prattle on about assessment. So I am, anyway, this is working. So I'm Aidan. I have moved recently from Australia to Ottawa. We've got someone in the waiting room. Let you in. As recently as November last year. So I have been told that it was a very, very bad time. It was not the correct timing for that one. Though it was nice. It was good, and particularly the snow and the ice and things like that made for a very exciting winter away from Melbourne's the day that we have today, which was relatively clement but quite grey, is most of Melbourne's winter, so quite a while. So it was a nice shock. Brilliant to be here. I'm so pleased to be in Ottawa, which is just a really lovely city so far. I was working as a clinical psychologist in Australia. I won't go into too much detail with what that means and the endorsements and things like that. Will be here forever. I was working in a number of different contexts. So I was working in private practices. I've worked in hospitals. I worked in chronic pain for a little while. But relevant to today, I've done a stint in primary schooling. I've done a stint in secondary schooling. And I worked for a little while, at least as part of one of my internships. I was attached to a university clinic that served both the university students and the greater public. So it was a discounted clinic for that was attached to the uni for the public to use and for the students to use if they wanted to. And as recently as last year, I was teaching in postgraduate level courses. So I was designing courses in adult interventions, so specifically things like acceptance and commitment therapy, cognitive behavior therapy, metacognitive therapy, and trauma focused CBT. And then I was additionally lecturing in our courses on psychopathology and psychological assessment, which is here we are. So looking at today, there's really sort of three things that stood out to me from the questions that you had posed, Karen, and the overall things that I think is important to talk about when it comes to assessments. And I will say, I guess, out the bat, just off the bat here, that I know there is probably going to be some difference in the level of exposure to assessments. So I know a lot of the psychologists and psychological associates and some of the fellows have probably been exposed to things like intelligence testing and psychometric testing. I don't know, and I please correct me if I'm wrong, that may not necessarily be universal, especially for psychotherapists, RPQs, and things like that. So as I go, I may use acronyms, or I may reference subtests and things like that. If that's unfamiliar to you, please just yell out. I do not mind being interrupted. That is a-okay with me. If there is a question or something that I will get to, I'll let you know, and there'll definitely be time for questions at the end. So if I'm prattling on about the Wace or the Wyatt or whatever it is, and you're sitting there going, what the heck is the Wace or the Wyatt? Then please stop me and I'll happily expand. So I want to talk today a little bit about what are the principles of high quality assessment. So what is a high quality assessment all about? How do we apply assessments in a variety of contexts? Excuse me. So are they standalone? How do they enhance therapy? Where do they go? Where do we go with this? And then a little bit towards the end, looking at the future of assessments. So where are assessments going over the next couple of months? Where might they go over the next couple of years? And there's an elephant in the room that we will get to when we get to that piece. So what are the principles of high quality assessments? Has to start with understanding what is psychological assessment. So there are a lot of definitions out there, and everyone has had their own 2 cents in this matter. For the sake of standardization, I've just pulled this from the APA's guidelines, that assessment is a complex activity of integrating knowledge, clinical judgment, reliable collateral information, and psychometric constructs with expertise in an area of professional practice or application. Every definition of psychological assessment orbits these same concepts, that we're integrating knowledge of psychological theories, we're making determinations about a client's difficulties, we're pulling in information from multiple sources. That's from the client themselves, from significant others. In the case of young clients, that might be from parents, might be from teachers. And what we're really talking about today are the psychometric constructs. So we're using standardized assessment measures to enhance this process. You will all do assessments as part of your day-to-day. Whenever you see a new client, you will be doing something of an assessment. And I like to break that down into evaluation. So an evaluation is one component of a broad assessment. And it typically involves semi or unstructured interactions with the client. So that might be a clinical interview. That might be a behavioral observation that you make in session. It might be a mental status evaluation. It might be paying attention to how they come into the clinic. Are they on time? Are they late? We are going to be using some psychometric, we're going to be really referencing the psychometrics part of assessment, which is an instrument where behavior and responses are quantified, scored, and interpreted using a standardized process. So this is most common in things like the WACE or rating scales like the BASC. And these together form what we call assessment. It is a problem-solving process that puts together information from the evaluation and a psychometric test to create outcomes for the clients. For me, that is the most important piece, is that it creates outcomes for the clients. And so my summary of high quality assessments are ones that invite the client in. They go beyond the scores that you get to create these meaningful and accessible outcomes for the client. Now, in my work, I'm usually with the client from beginning to end, from intake to feedback. So I'm doing all of these pieces. Now, this is going to be a little different. It might look a little bit differently. And we kind of have to think about that workflow when the clinician who's doing the therapy is soliciting the service from a psychometrist and getting them to consult on that. And I'll talk a little bit more about that later on. But for me, these are the three key pieces. So what does it mean to invite the client in? The first is that rapport actually matters. Even though an assessment, if someone is coming in and just doing the WAIS or the WIAT or whatever it is, it's not strictly a therapeutic encounter, but rapport can impact client efforts. If a client is sitting in front of me trying to complete a subtest on the WAIS and they don't like me very much, they might put in less effort, and that will show up in their scores. So what this means to me is that a sense of continuity is really important. So that means allowing them to ask questions during the intake, talking to them about the process. Once we've done our intake, where are we going? Where are we going after that? What can you expect from this whole process being put together? And building rapport through each of those steps, from the initial consultation call, if there is one, to the intake, to the testing sessions themselves, and finally in the feedback session, making sure that we're using all of this. That can mean in a testing session that we are allowed to provide encouragement where it is permitted. And so that is often in structured assessments gated by what the manual says we can do. And a lot of the times it will say that, doing, like, you're working hard, you're doing good work. We can provide global encouragement to a client to help keep them motivated and keep them engaged in the test. What it means from a scoring perspective is that we really want to measure their response to failure or difficulty. Now, transparency is part of that. Because I'm with someone from beginning to end, I can address their questions as they come up. And particularly when you're studying, particularly when you're new in the field, and it is really drilled into you from a very early stage that these tests are copyrighted, they cannot be sent, they cannot be seen, we can't get them out. It can really feel like we're the gatekeepers to this kind of stuff. And this can impact the quality of the assessments that we do, right? This is not a process that is being done to a client. This, like therapy, is a process that's being done with the client. And so it's important for you to be able to work with the client and set those expectations. What are they allowed to ask? When are they allowed to ask this? I will often set the expectations with the client that I don't mind if they shoot me an email, but with a question that's come up about the process. But I will set the expectation that I'm not necessarily going to reply to that straight away. It's also where we need to sell this to them. What is the outcome? What is the benefit? Why are they going through this process? And why am I doing the tests that I'm doing? I can speak to a recent encounter where I had someone ask me, why have you selected this questionnaire? And it was a wonderful question. It really created an opportunity for us to talk through this and say, well, based on the background, based on what we've talked about, I think this is a really valuable piece for us to rule things in and out, which is an important part of the process, at least in my perspective. So it's always guided by the client's questions. Clients come to assessments with specific questions. Even if they've been referred by someone else, they have started with a question somewhere. That might have been a question that they had with their family doctor. I've noticed this problem. I'm wondering what explains that. Now, that question doesn't rule out possibilities. If someone says that they're coming in to screen for ADHD, that doesn't mean that we're not paying attention to all of these different possibilities. It could be things like a trauma background, it could be autism, anything like that. But it does focus our attention at the outset. And it's going to guide how we talk that client through the selections that we've made. It's also why I'll tell clients that I tend to start broad. I'm going to ask them in a clinical interview, I'm going to ask them a bunch of questions that might seem unrelated, that might seem irrelevant, but I'm going to ask you about things like mania and OCD because I want to make sure that we're ruling in and out things that are important. And so finally, this teamwork piece, I mentioned a little bit about this before, is that the assessor and the client, they are a team. Right? Are the clients allowed to ask questions during the process? Are they allowed to ask questions between sessions? What's the negotiation for this? Just like in therapy, you're going to be negotiating with the client what kind of contact is permissible outside of sessions. And it's the same here. So set those expectations early to avoid disappointments later on. This piece here, going beyond the scores, I think is what really differentiates an assessment from a high quality one. That behavioral observations, what the client's doing, the process of how they approach a task is a huge source of information that can be left on the editing room floor by more novice assessors or by interprofessional collaboration. So when a clinician has solicited a psychometrist to do something, you can learn a lot from the way that someone approaches a task that isn't covered in a score. Some of my favorite examples of this is that you will see in subtests like cancellation or coding, you'll start to see some of that piecemeal processing characteristic of autism in how the client approaches that task. For example, I'm thinking about a child I assessed back in Australia. Their approach to cancellation was little pockets of marks as opposed to working through it in a sequence. You'll see people who have difficulty with response inhibition in things like matrix reasoning, where they immediately jump in with an answer and then will have to self-correct as they've processed it a little bit more. And so these subtest level scores, right, how did they do on this particular subtest? They're often forgotten. And this is doubly so when there's technology-assisted scoring and administration. So iPads, QAssess, Q Interactive, I'm looking at you. I'm going to sound like a very sort of assessment puritan for a moment. The paper score, hand score, everything. It is a wonderful tool, but we need to make sure that we're looking at the process and the subtest levels here. So although composite scores in assessments are typically the most stable and are the headliners, you can get much, much more mileage out of one instrument, make better use of the client's time, of your own time, by looking at subtest scores. So for example, if someone does much more poorly on coding than other processing speed subtests like symbol search or cancellation, that might be a motor issue. The handwriting element might have been a problem there. You can compare things like figure weights to arithmetic, both based in mathematics, but one is on a page and one is in their head. And so if they do well in figure weights, but less in arithmetic, it tells us there's perhaps something going on with the performance aspect of arithmetic. Even within one subtest like matrix reasoning, how did they do on the sequential items, like taking one rule and applying it over and over again, as opposed to looking for two rules that they need to put together? So this next piece is a little bit contentious to deviate from the manual. It is allowed within the scope of administration, and typically it's post-administration. The manual, for example, does not tell you to seek qualitative information about the process, but you're perfectly permitted to do so. In the WISC, for example, working with children, when you were doing the picture, I forget the exact name of it, the fluid reasoning test where they're picking a section from a child, sorry, an image from the top row and the bottom row. You can go back at the end of the assessment and ask them why they chose certain things that they did, if they were incorrect or even if they were correct. And this can tell you that the child is perfectly capable of forming logical connections, but there was a knowledge gap with what was on the page. And that's hugely beneficial qualitative information that should be going into our evaluations and our assessments and ultimately our reports. And that's where this comes in, which is we're synthesizing psychometric and clinical evaluations. These are not in isolation. We are not trying to reconcile scores on an assessment with what came out of an interview or vice versa. That is, if the client tells us one thing and the test tells us another. These are not in opposition. We need to come up with an explanation of how do these fit together in the context of each other. So how does the interview make sense in the context of the score? And how does the score make sense in the context of the interview. We need to put these pieces of the puzzle together to make sense. And as I've said, that can become trickier when there is someone doing therapy and they've asked for an assessment. It's primarily the reason I like to do my own, is that I can make sure I'm getting this qualitative behavioral information, and I can put it together with this with the interviews that I've conducted. But I'll talk more about that in a little bit. So finally, assessments have to lead somewhere. They have to be going somewhere for this process. There must be a payoff to going through this lengthy and expensive process. The only part of the assessment that's useful to the client is the end product. That could be an insight, it could be an understanding, it could be a report, right? I always think about one of my early lecturers who, whenever they would mark an assessment, you would always see next to a paragraph just the phrase, "so what?" Right? What's the conclusion? What's the benefit? And that's so true with assessments. If they don't lead somewhere, what was the point? The so what of the assessment is really key. Now, that may depend on the setting. Clients will seek assessments for many reasons. That can be diagnostic, for additional context for their own experiences, an explanation for their difficulties. Those insights could direct therapy later on. It could help clients gain accommodations at work or access other support services. It could be required by a court and affect, in a really material way, their next few years. So we always have to be aware going in what the desired outcome is. If the client comes in with a particular outcome in mind and we go into this willy-nilly, the end is going to be where we have to have that difficult conversation. So only take on what you're comfortable taking on, right? Be clear about these at the beginning to avoid the awkwardness and disappointment later on of having to explain to a client, oh, we've done this assessment, I've written this report, but I wasn't writing it for a court context, and I don't show up to court, as as far as that would fly. So assessments are not for us. Assessments are client forward. They are not just for us to have fun playing in psychology. And even though assessments are useful for therapy, better therapy is for the client, right? So good therapy is for the purpose of being assisting with the client. So it itself is client forward. With freedom of information, clients can access the reports even if we don't intend for that. And even if we're writing a report to a family doctor, the clients will be able to request that. And so it is extremely likely that a report will be read by a client, which means these need to be written with clients in mind. They need to be written at the level that the client can interpret and understand. Right? Even the best psychological insight is wasted if it is not accessible. Right? If the most beautiful statue is at the most remote location and is not visible by anyone, then we're not making the most of that. So for me, those are the pieces of high quality assessments, is that they invite the client in, they go beyond just the top level scores, and they create some kind of outcome. But where do we apply these? What's the purpose of this? What do those outcomes look like? What are the applications of psychological assessment? The first, and perhaps most common one at the moment, is that they support diagnostic outcomes. So formal assessment tends to be siloed away from therapy and private practice, and the cost is often prohibitive to integrate with therapy, even in well-resourced practices like Ottawa River Integrative. And so the main outcome is typically a diagnosis and a report that's used by the client to explain their difficulties in their day-to-day life. They're often seeking an explanation or potentially an access to a support service, like an accommodation at work or uni or school. What most people tend to think about when they hear assessment in this day and age is neurodevelopmental disorders like ADHD, ASD. And current guidelines, so both the APA's guidelines, the guidelines in Australia as well, prohibit the diagnosis of ADHD based on rating scales alone. The assessment of ADHD requires neuropsychological testing, multiple information points, and observations. And this is probably like 90% of the work that I'm doing here at the moment. And this is aided by how popular, how free discourse around these things has been. I'm not going to say anything about TikTok or anything like that, but the fact that people are talking about these things does mean that we're seeing more people come through our doors going, hey, this might be an explanation for why I've had these difficulties my whole life. They can also aid diagnostic clarity. So personality assessments like the PAI or the MMPI can provide broad perspectives on clients' functioning. And with careful interpretation, we can reveal patterns consistent with diagnoses, comorbid presentations. I famously love the MMPI. It's almost like the perfect clinical interview that you just get to like indulge in while you're working through the scores. And so I'm sure no one will agree with me on that point, but it is a great joy. So lots of really detailed information in there. So assessments are also useful for an educational context. So in Victoria, in Australia particularly, there was a big push for the schools in psych programs. So that was at a tertiary education level. A lot of placements were coming through, but also at an employment level, there was a lot of funding available to hire psychologists to work in schools. And that was both to support mental health of students, but also to drive assessments. Now, I don't know if that's the same here in Ottawa or Canada broadly, but even well-resourced schools may not have those opportunities available. And so as a result, private practices like us, we need to be ready to provide services to support those families, particularly families who are attending less well-resourced schools, to look at getting assessments and getting the children the best chance at school. In particular, it is really important for diagnosing specific learning disorders. So dyslexia, dyscalculia, dysgraphia, things like that. Previously, they were diagnosed by achievement ability discrepancy analysis. So is the child's performance on the WISC much greater than their achievement academically on the Wyatt, and looking at those? That was useful and is still important because it reduces the effect of non-standard assessments at schools. Is this school assessing reading, writing, or whatever it is in a particular way or a standardized way? The current diagnosis is done by response to intervention. So taking a starting point, working for 6 weeks with a kid with intense instruction in reading or whatever skill it is, and measuring that. That's complicated because there is a 2-year minimum period of time between assessments that they can do with this kind of thing. But setting up that basis at the school and those individual learning plans is really key. So accommodations are a huge part of it. So assessments lay the foundation for designing like bespoke, individualized accommodations to support students. And it provides a breakdown of specific skills like reading, maths, spelling, writing into their component pieces. So for example, the Wyatt has 2 oral fluency tests, subtests, one which involves reading a list of words and one that involves decoding nonsense words to differentiate between the use of context. And this allows teachers and educators to really zero in on their interventions, their remediation. And it also allows us to create a team, an assessment team, that really advocates for the needs of students. The amount of times I've had parents telling school that, you know, little Timmy or whoever it is really struggling or is behind, and it's falling on deaf ears. Or vice versa. The teachers are saying this, you know, little Sally is really struggling in class, but parents are, for whatever reason, like they're too busy or they're not confident enough to support this homework at home. A lot of that noise gets cut through by quite an authoritative sounding report from one of us. And it can create a situation where we stop kids falling through cracks because we can come in and advocate for what this child needs or what this older student needs if we're looking at university. And how do we go about specifically creating that? And finally, assessments support therapy. So clinicians are doing assessments all the time. Like I said at the beginning of this, your interviews, your observations are often smaller versions of these bigger assessments. You will ask questions when assessing anxiety that the BAI will use. You're asking questions around history that the MMPI will cover, but you don't need 335 items to cover it. You can do this in a few. So you'll extract those same variables while eschewing the bigger administration time. And those then form the basis of treatment planning. It's prioritizing treatment targets. It's designing interventions. It's designing your format of treatment. How often do I see this client? In what setting is it best to see this client? And more formalized assessments may be able to bypass the reliance on self-report. So an interview and impression management in the room, and client engagement and motivation. So often sending them to me and saying, Aidan's going to do some test with you. In the case of like a WACE, can get around the self-report bias, but also create sort of a reset in engagement. Similarly though, you'll use psychometrics throughout the therapy process to monitor the effectiveness of treatment. This is likely not going to be a giant assessment like an MMPI that takes a long time to administer. It's more likely a short form like the DAS or the BAI or the GAD-7. But I think we all broadly understand that monitoring treatment effectiveness is important, is useful, and is often required. And so finally, like I said, the MMPI is like a perfect clinical interview, and using those tools can reveal hidden details in tricky cases. There might be details that don't get uncovered by less formal processes, things that just didn't come up in your conversation, in your interview, or things that took a back seat to a client coming in saying, I'm really anxious about this thing that's coming up in the future, and that's what I want to talk about. That's all I want to talk about. And all of this other background information is sort of hidden behind that. And so those details that are missing can lead to treatment that's complex. It can lead to treatment that's meandering or otherwise ineffective. And so you might consider looking at an assessment when treatment doesn't seem to stick. It's just sort of feeling a little bit, it's a little bit diffuse. We're sort of moving here and there, and we're not seeing as much traction as we would otherwise expect. Which leads us to talking about how do we collaborate with each other in an effective way. And it's always about a clearly defined referral question. Everything coming back to that referral question is the key to a productive relationship between a therapeutic clinician and a psychometric assessor. Assessments in a vacuum are just scores and are going to be limited to generic interpretations. I often look at the interpretive reports that Q Global spits out, and it is very surface level, it's very generic, and that's what we're going to be limited to if we're not working closely together. So defining a key referral question is important to getting these high quality assessments. What kinds of behaviors in session are we looking for? What should we be on the lookout for when this client is engaging in a WACE? What do you want to come out of this assessment? Feedback is often a scary word, and feedback needs to go both ways. Now, this is particularly important when there is a therapeutic clinician with less experience in assessments. So feedback from psychometrist or assessor to them can help inform instrument choice. If you're hoping to test a specific hypothesis with a client, tell the psychometrist, I'm really curious about this person's, response to failure. Okay, what tests can we choose that are really going to push that push that piece. Does the assessor have an idea of what test, what instrument might reveal relevant results to testing that hypothesis? And so we're very lucky here at Ottawa River Integrative to have quite a well-resourced assessment team. That there's probably an assessment that we have that is in the big category that many people probably haven't spent a lot of time looking at, that could be used to test a specific hypothesis that you have for a client that might not necessarily immediately come to mind if you were saying, yeah, give them a PAI. So whichever clinician is interpreting the assessment needs the good qualitative data that we talked about earlier. Remember what I was saying before about behavioral interventions and subtest level scores? That means that we need to work closely together. Now, that could be done in a number of different ways. That could be a hypothesis sharing session prior to the referral or prior to the testing. It could be a debriefing session between the assessor and the clinician. It could be requesting videotapes of the assessment session itself so that you can go through this and extract the data that you find most relevant. And obviously, I don't think it's particularly surprising that collaboration needs to be driven ethically. The sharing of information needs to be agreed to by the client. There needs to be written, signed consent that they're okay to bring a third party into this therapeutic relationship. So consent at any major change to the psychological service, like bringing in an assessor, needs to be documented, needs to be consented to. It also means that you can discuss this in therapy. Take a session and discuss with the client. I think it would be really useful for you to go through a process of assessment with Aidan, CV, Sonera, whoever it is that's here. And you can lend the assessor some of your goodwill in that sense, that they can go into that testing session with a sense of, oh yeah, Karen or Paul or whoever it is said, yeah, this is a good idea. They've implicitly vouched for Aidan. I'm going to go ahead with that one. It also means that there's less risk of hitting reset on that therapeutic alliance, that they come out and do a testing and then come back in going, what the heck was all that for? So that's the state of play as it is. And where to from here? I'm only going to talk about a couple of things here. I want to try and keep it a little brief. Most exciting thing, I think, on my plate, again, apologies for being a bit of a psychology nerd, is that the WAIS 5 is coming very soon. So the WAIS gets updated infrequently. WAIS 3 was 97. WAIS 5 is 24. I can't remember the exact year for WAIS 4, but effectively once every 10 to 13 years. And that's going to bring some huge shifts in assessing adults. So for anyone unfamiliar, the WAIS is the Wechsler Adult Intelligence Scale, and is one of the primary tools that we're using to assess things like ASD and ADHD in adults. The WAIS 5 is bringing updated norms. That alone is huge. Historically, scores tend to trend upwards. So when they first release a test like this one, the average is 100. If you were then to, over the course of a few years, the scores tend to get better. So people tend to sort of sit around 103, 105. And if you were to go back and do an old version of the WAIS, like the WAIS 3, you're probably going to score quite highly just on the nature of being average. So these norms reflect changes in education and social technology. So it brings these scores back down to a standard level. It's going to be aligned with the 5th edition of the WISC, so the child scales that were released quite a few years ago. It's the big updates there are we're changing some of the subtests. It's splitting perceptual reasoning into fluid reasoning and visual spatial intelligence. So it's teasing those pieces out. And it's adding a lot more, it's codifying a lot more tertiary or ancillary indices. So the GAI, or the General Ability Index, is an overall measure of intellectual functioning, like the IQ, the full scale IQ. But the GAI is less impacted by performance tasks like working memory tasks, processing speed tasks. So you'll often see a high GAI and a lower FSIQ in clients with ADHD. That's backed up by the cognitive processing index, the CPI, which is just those performance elements. Again, I'm not going to go on, I could prattle on about the weight 5 changes all day. I'm not going to bore anyone. Suffice to say that it's codifying a lot more granular scores that's going to be able to allow us to point in specific directions to really enhance what we offer and really update our interpretations. And ultimately, what it's doing is it's cutting administration time as well, especially for those who are scoring highly or are gifted. The core subtests plus digit span forwards is roughly 45 minutes. And the full gamut of tests, including digit span forwards, is going to be 60 minutes. So that is a huge reduction in time from the average of 1.5 to 2.5 hours that we're sitting at the moment. So it's a huge change. It's going to mean that costs will go down. It's going to mean that therapist time, it's going to mean assessor time, and it's going to mean client time is returned to them, which is tremendously exciting. But the elephant in the room is what's here already. And I'm sure we all know that AI is everywhere at the moment. And for better or worse, I am not getting into that moral debate. That is something for you to do in your spare time. But the fact of the matter is that AI is showing up in the therapy encounter with note taking. It's showing up in public with people using ChatGPT as a therapist and as an assessor. And it's showing up in assessments too. So we're going to have to work to try and maintain relevance. And so formal psychological assessment already loses out to less psychometrically valid instruments that are freely available, right? You think about the Myers-Briggs type indicator, a very wonderful tool to start discussions, but it's not a psychometrically valid test. And so generative AI is likely to add more pressure for clinicians to sell assessments to clients. What is the purpose of going through this lengthy and costly process when I could do this freely available thing and I could plug it into ChatGPT or Gemini or Claude or Grok or whatever it is to interpret this? So AI is great at presenting itself as an expert. And if clients don't see the full value of an assessment, and what I mean by that is that we're delivering high quality assessments that lead to meaningful outcomes, we're going to lose out to this changing digital landscape. And that digital landscape is already modifying our assessments themselves. So there is already development of consumer grade Gen AI. So that's ChatGPT, Gemini, things that are freely available to the public and not bespoke LLMs that are leading personality assessments. So this Wright study from this year, they had clients just speak freely and sent the transcript to ChatGPT and a bunch of other models and said, great, answer the NEO based on this transcript. And it was fairly effective, right? It had better alignment with the client's NEO than their family and friends. So we're already seeing that. That's a wonderful way to do this. Some people are suggesting that it could reduce the reliance on self-report. We don't have to ask clients questions because we can plug them in to a fictitious scenario that they can respond to in a naturalistic way. That study, the Tewitt Addison, not a study, the article from Tewitt and others was in a HR field. And so it's likely to run into similar issues with like effort. And we could be tricked into thinking that moving away from self-report completely is a great thing. But there's some suggestion that that's where it could go. But this comes with risks. So particularly consumer grade LLMs like Claude, Gemini, etc., are trained on data sets of specific information. And Thus, they run the risk of existing in a form that is replete with entrenched stereotypical information. And they run the risk of advancing that or affirming that. So we need to position ourselves in a place that is culturally informed, that this assessment and this process and this interpretation is being driven by the client's cultural background, their cultural backdrop, to combat the potential for AI to really operate in a space where it's affirming this and not being unhelpful. An easy, sort of quite agnostic example of this is that ASD or autism in MMPIs and in Basques will often look like an elevation in the psychotic subscales. And so there's a risk of superficial interpretation going out there telling a bunch of people that they've got, schizophreniform disorder or schizophrenia type disorders when really they might be autistic. So we need to make sure that we're sort of coming to assessments with that space. So in summary, high quality assessments invite the client in, they go beyond scores, they create outcomes that are meaningful and tangible and are accessible to the client. They enhance diagnostic outcomes, they improve educational outcomes, and are relevant in the therapy room and allow us to advocate for clients' needs. And assessment tools are constantly evolving. We're always developing new tools, and that they can and should make use of advances in technology, and psychology practices should be responsive to changing client needs and changing client expectations based on those technologies that are out there. These are the studies that we referenced just for anyone's, I think you'll get the slides, so just in case you want to refer to them. So enough of my prattling. What's on everyone's mind? Talk to me about this.
Can I just say thank you so much? Go ahead, Colleen.
Is Christine in this meeting?
I don't think so.
Okay.
I think she's quite busy from what I've heard from her this week.
Yeah. Okay. So I'm a psychologist, but I have drifted from assessment to be more of a therapist and interventionist, and I actually want to course correct that. And so this question is very conceptual and very clinically based, and I'll sound like a rank amateur, and I don't care because I would like your perspective, please. Because I got over my ego a long time ago. One of the things that I have learned in my practice over the years is how profoundly anxiety and specifically trauma can have an impact on cognitive function. And so I'm thinking of someone right now, which is actually why I didn't want to have this conversation with Christine, because I adore Christine. It has to do with her clinical work, it has nothing to do with her opinions or any of that. They probably shouldn't have even mentioned it. So I'm working with an adult who is having all sorts of high anxiety. It's having a direct impact on her work. But she's also living in a very psychologically abusive environment where she's constantly hypervigilant, and should be. And so I have a bias that daily, hourly experience would overwhelm or misguide what a formal assessment could show. She's not asking for a formal assessment, but she's frustrated by the impact on her work as she's trying to finish up a major goal. And so, and my other thought is, if I were writing a report on that, I don't know that I want to go into that much. A report is often something people share, and I don't know that she would want that in a report because she's still in that unsafe situation psychologically. And so, she's a psychologically unsafe situation. And so I'd just love to hear your thoughts on that as someone as a pro in the area, because it's where I can feel my mind glitching a bit.
It's such an interesting question, Colleen. Thank you. And it's a very nuanced thing, right? And
Mhm.
this is where, I mean, there's at least my conceptual, there's a few different pieces in there. So I'm going to try and tease them out best I can. If I miss something completely,
Please, yeah.
just please correct me on that one. First of all, you talked about the impact of the mental health symptoms, the anxiety, the environment on the assessment results, and you're spot on, right? Absolutely spot on. And obviously, I don't know this person at all, and so this is obviously it would be a client by client decision of if we were to go down an assessment like a WACE or like uh, again a wide, like I won't rattle off tests because I don't think that would be helpful. Um,
Might
that
not
would
know them.
that would bias it. You're absolutely right. And some, if that comes out well, if that comes out, actually, you know what? Cognitively, you're okay, like you're
Yeah.
average or better than average or whatever it is.
Mhm.
That might be really reassuring to the client.
Mhm.
Maybe. But on the other hand, if exactly as you say, this person is always heightened, is in that fight flight mode constantly, and that has a material impact on their assessment scores, then that's going to be completely devastating to them
Mhm.
because they're going to see this number and go, oh, I'm an idiot. And that's
Mhm.
so far from the truth.
Mhm.
Um, which then leaves us in this really unhelpful space of we did an assessment. It said that you were below average or whatever it is, but that's because you're really anxious. The client's probably going to
Mhm.
go, yeah, I know I'm anxious. That's why I'm here.
Mhm. Mhm.
And so if it's not therapeutically relevant, a cognitive test may not be something to look at. There may be something along the lines of, I mean, I'm always going to advocate for the MMPI because I'm a huge nerd. But getting some of that information can, sometimes we can point this to clients and go, actually see these elevations on this, dysfunctional negative emotion scale and this
Mhm.
demoralization scale. How do you think that's impacting you? How do you think this explains your experience? Can sometimes open up those really interesting conversations. The
Thank you. Yeah.
the other piece that you mentioned was like reports and what
Mhm.
do we put in a report, because you're right. And I'll often say to clients, like, I'm bound by confidentiality. I'm not going to show the report to anyone, but I'm going to give you a copy and you can show it to whoever you wish. But I'm also going to talk you through it, and I'm also just putting information into here that, I mean, I was trying to get at that vain, like for vain reasons, are showing like, is this a good psychology report? Oh yes, it is a good psych. We should. Aidan's great at writing psychology reports, right? Hugely vain, but vanity was, I think, the word I was looking for. Um, but that's not always the most useful thing to clients, and there is a huge
Mhm.
debate, and there's no agreement, and that's true of Canada. It's true of Australia. Of what scores do you put in a report? And I'm willing to bet that everyone here will have a different answer. And some people will not put composite scores in a report. So your IQ is XYZ.
Mhm.
Instead, we'll put percentile ranks.
Mhm.
You performed better than 55% of people. That I think is useful enough.
Mhm.
Um, but there are
Yeah.
assessment theorists that I know here and back home who go, no, 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 no. You definitely put composite scores in because if it goes to another site, you need it. That's always a conversation to have with the clients. And often what I'll do
Okay.
is a compromise with an appendix of, this is the report. These are the scores that I think are clinically useful, but the appendix contains the full breakdown. There's no need for you to look at it. You can show it to anyone you need to. They won't mean anything, but they're there in case you need them. I hope that addressed the question a little bit.
Yeah, it's super, super, super helpful. I can't even imagine how much more complicated that gets with kids, right? I attended the Indigenous talk, most of the Indigenous talk yesterday, and she started by talking about adverse childhood experiences. And, when I think of how that affects a little one's brain, it's heartbreaking.
I think
brain and test scores, of course.
I think you're preaching to the converted there, Colleen.
Yeah, I can't imagine how you sort. I don't work with kids because I can't process that. I can't be professional as required. So all hats off to you.
Okay, I appreciate the reflection. I know we're sort of approaching 2. I don't want to keep anyone here past
Oh, yes.
bell, but are there any other questions or any other thoughts? I'm keen to hear.
Aidan, if we wanted to talk to you about options for assessment for a client where we're really not sure whether an assessment would be helpful or not, what's the best way to approach you? What information would you want from us? And how do we develop and facilitate that professional relationship so that we're being supportive of clients, so we're not encouraging them to invest thousands of dollars in an assessment that may not actually be helpful. And in the meantime, they're running to their family doctor and getting prescription medication for self-diagnosed ADHD, for example. How do we maintain that professional relationship amongst all the people that are involved in the psychological care of a client to make that work well?
That's fantastic. And I think it really speaks to a lot of the change that we've been trying to create and trying to see in the assessment section, the assessment team, over the last couple of months to try and streamline that process and make sure that these aren't 2 silos that exist in the same practice, that this is one cohesive practice. If you ever need me, I'm an email away. I'm always happy to nerd out about psychology. That's just a given. So you can tackle me to the ground. Totally fine. In terms of where to go with that, where do we start with? I'm always most curious about why, right? Like, why is this on the radar? What is it about? What question are you hoping the assessment will answer? Everything else sort of comes from that river mouth. And we're so lucky here at Orem because we have an assessment arm, like we have these assessments. And I know in my own work in private practice back home in Australia, that when there wasn't an assessment arm in the clinic, often I would try to MacGyver something together of like, how do I get a result that's similar to what I want, but I'm not able to access formal testing like an MMPI or a PAI or a WACE or a WIAT or whatever. Like, how do I do this? How do I get that? And so the fact that we're here, that door should be flung open as best we can. You're right that it's costly, and that's always the tricky part. Every other piece of information for me comes back to, why are we doing this? Why are we trying to do this assessment? What do you want it to tell you? And that's really all I need to get us started. Everything else just is a conversation that evolves from that point. So if there's ever someone you're thinking about an assessment for, find me. You can also find any of the assessment team as well. So Asta, Tripti, CV, Sonera, anyone who's in there. I apologize if I've forgotten anyone. I only meet people frantically. So I apologize to them. But come and chat to us. You can always shoot us an email. My email door is always open, is probably the shortest way to say that.
Awesome.
Fantastic. Any other questions before, again, I don't want to keep anyone back past the time. A lot of people would dive off to clients. So
this was incredibly helpful, Aidan. Thank you so much for putting that together and for making my role as the host so easy, because I got to just sit back and absorb information. It was wonderful.
I appreciate it. Thank you for the kind words. I'll make sure that a PDF of the slides are passed on to.
Oh, amazing. Yeah.
You've got them and you can pass them out to whoever you need to. Again, thank you for having me and letting me nerd out about psych assessment. It's always a bit of a guilty pleasure, so I appreciate that immensely. And if there's ever any questions or you're ever curious about assessments or what they look like or what reports might look like, track down a member of the assessment team, come and chat to me. I'm always available. But thank you all. Have a wonderful afternoon. Enjoy the hot weather we're having.
Bye.
Yeah.
Thank you so much, Aidan. That was fantastic. Really appreciate it.
Thank
Happy
you.
Easter to those who celebrate.
Indeed, indeed.
Thank you.
Awesome.
Bye.
Thank
Appreciate it.
you.